It's my pleasure now to introduce one of the most senior consultant endocrinologists in Saudi Arabia. Dr. Abdulhamid Kashgari is our next speaker. He's a board member of SHMS. Please, Dr. Hamid. He's going to talk to us about hypertension, emergencies and urgencies.
Dear colleagues, ladies and gentlemen, hypertensive crises include two things, either hypertensive emergency or hypertensive urgencies. Those are not only blood pressure increase, but clinical condition. Increase in blood pressure more than 180 systolic and more than 120 diastolic, but in association with clinical condition. And this acute increase in blood pressure should be lowered rapidly, but controlled to avoid and limit the risk of complications. Hypertensive emergencies represent 25% of the hypertensive crisis. 25% of patients with hypertensive crisis, they present as hypertensive emergencies. And the majority, 75%, they present as hypertensive urgencies. What is hypertensive emergency? It is a severe elevation of blood pressure, more than 180 systolic and more than 120 diastolic, and evidence of acute target damage. Not only increase of blood pressure, but evidence of acute target organ damage. It's a life-threatening condition because the mortality is high if not treated, and it requires immediate but careful intervention. Hypertensive emergency is diagnosed, as we said, if the systolic blood pressure is more than 180 and the diastolic more than 120, and at least one of the following clinical condition is present. Either ischemic stroke, pulmonary edema, hypertensive encephalopathy, acute heart failure, acute MI, intracerebral hemorrhage, eclampsia, dissecting aortic aneurysm, subarachnoid hemorrhage, acute renal failure, pheochromocytoma, or clonidine withdrawal, or amphetamine and LSD use. The most common clinical presentation, as shown here, is either ischemic stroke, 1/4 of the presentation, or pulmonary edema, or hypertensive encephalopathy. The pathogenesis of hypertensive emergency is not fully understood, but understanding underlying causes are mostly essential hypertension in 90%, but also renal hypertension, malignant hypertension, and preeclampsia, pheochromocytoma, and cerebrovascular disease could be. The pathomechanism is also not fully understood, but generalized vasoconstriction, cerebral edema, and spasm of cerebral vessels, and activation of renin-angiotensin system and sympathico-adrenal system could be the cause. We have to do emergency investigation, short history and physical examination, repeated measurement of blood pressure to confirm the severe elevation of blood pressure, ECG, chest X-ray, and fundoscopy should be performed. Some lab investigation like serum electrolyte, creatinine, urea, urinalysis, complete blood count, and troponin and CKMB if needed. Abdominal ultrasound if dissecting aortic aneurysma is suspected. Echocardiography if needed, and CT scan of the brain if neurological deficit is present. What is the treatment strategy? Sometimes immediate treatment is needed before diagnostic tests are completed or before laboratory results are available. But remember, as Hippocrates said, primum nihil nocere, first do no harm. Don't treat the patient and cause harm to him. You should give him benefit of the treatment, but no harm. The treatment strategy we should treat the patient and not the number, not the blood pressure. You can have a patient with a blood pressure 180 to 120, but he has no symptom. You should not treat him like emergency. So we should treat the patient and not the number. The clinical presentation and rapidity of blood pressure rises are more relevant than the actual level of blood pressure. Treatment of hypertensive emergency include general guidelines. We should treat the patient immediately. We should lower the blood pressure within 30 minutes to avoid and limit the risk of serious complications like cerebral hyperperfusion, perivascular edema, and increased intracranial pressure. But we should lower the blood pressure controlled to a safer non-critical level, but not to a normal range. The reduction of mean arterial pressure should be by 25%, and the aim systolic blood pressure should be 160 to 170, and the diastolic blood pressure 100 to 110. The controlled lowering of blood pressure is to avoid sudden drop of blood pressure and reduction of cerebral perfusion and development of brain infarction. Close observation as inpatient is required. The medical treatment of hypertensive emergency depends on the clinical presentation. Not every clinical presentation is like the other. No treatment should be started without clinical evaluation. The clinical evaluation should be performed without delay. This list includes the most commonly used drugs. We need, in fact, to remember or to have some drugs in our mind. As you see, I highlighted them in some colors. Nicardipine and labetalol are commonly used. They are first-line treatment for several conditions, but nitroglycerin is also used, and some other drugs like phentolamine and so, they are not commonly used. As alternative, I am mentioning here orapidil. Maybe it is new or strange for some of you. It is used in fact in Middle Europe as first-line drug, and it is a very good medication with a low side effect profile and which can be used also in stroke. The dissecting aortic aneurysm is important because we need to lower the blood pressure rapidly and to a low level, and the treatment is esmolol with nitroprusside. Nitroprusside is not commonly used nowadays because it has severe side effect and the patient must be monitored in the ICU. I don't know how many of you did use nitroprusside in last time. This list includes the commonly used drug in hypertensive emergency with the side effect, the possible side effect, and the contraindication. As you see, nicardipine is a good drug with side effect like headache and reflex tachycardia. It is similar like nitroglycerin with the side effect profile. And the beta blocker, like labetalol and esmolol, they can cause bronchoconstriction and they are contraindicated in asthma and in bradycardia and in AV block, second and third degree. I don't know how I am with the time. Shall I go further? This list includes the drug characteristic showing to which class every medication will belong. Nicardipine is a calcium channel blocker, labetalol is alpha and beta blocker, nitroglycerin is a vasodilator, esmolol is a beta blocker, and nitroprusside is a vasodilator. Phentolamine is alpha blocker, and urapidil, this drug which might be not known to every one of you, is alpha blocker, but with a central acting component. The onset of action, as you see, is relatively quick, relatively fast, between 1 to 5 minutes in nitroglycerin and 5 to 10 minutes with the other drugs. The duration of action is written there. The duration of action in most of the drug is not long. That's also a wanted effect because we want to treat the patient and to monitor him in the ICU or as inpatient. The goal of blood pressure is different in special presentations. So if we have aortic dissection, as I said, we should reduce the blood pressure to less than 120 systolic in the first hour. It's the rapid and sharp reduction of blood pressure, of high blood pressure, if we want to save the life of the patient because he has aortic dissection. In most other cases, like in severe eclampsia, in intracranial hemorrhage, intracerebral hemorrhage, or in pheochromocytoma, we should reduce the blood pressure to less than 140 millimeter mercury systolic in the first hour, not immediately in the first hour. In ischemic stroke, there is a lot of controversy, as you know. We heard it also yesterday and today. We should reduce the blood pressure to less than 180, the systolic blood pressure, and the diastolic blood pressure to less than 110 millimeter mercury in the first 24 hours, not in the first hour. So in ischemic stroke, we have to be careful.
Got 5 more minutes, please.
Sorry?
5 more minutes.
Okay. Hypertensive urgency quick. It's also severe elevation of blood pressure, more than 180 and 120, but with non-specific complaint and without evidence of acute target organ damage. It has less serious prognosis than hypertensive emergency in spite of severe hypertension. In fact, more of the hypertensive crisis presentation, 75% of them are hypertensive urgencies. Hypertensive urgency is diagnosed, as we said, if the systolic blood pressure is more than 180 and the diastolic blood pressure is more than 120. and at least one of the following clinical situation is present. TIA, chronic heart failure, ischemic heart disease, perioperative hypertension, status post-renal transplantation, or severe diabetic retinopathy. The treatment of hypertensive urgency is different. We should reduce the blood pressure immediately, but within 24 hours, not within 30 minutes. And we should lower the blood pressure controlled. We should reduce the mean arterial pressure by 25%, and the aim diastolic blood pressure should be 100 to 110 to avoid sudden drop of blood pressure and cerebral hypoperfusion. Outpatient treatment of hypertensive urgency is possible. The medical treatment, it should be oral antihypertensive medication. We should continue on the regular medication and intensify them. There is no need for parenteral medication like in hypertensive emergency. This list includes comparison of the symptoms with hypertensive emergency and urgency. In hypertensive emergency, on the right, the patient presents with more severe symptoms like chest pain, dyspnea, neurological deficiency, and somnolence. In hypertensive urgency, the patient, they have non-specific symptoms like headache, somnolence, less, and chest pain and dyspnea. Not every elevation of blood pressure more than 180 systolic and 120 diastolic is an hypertensive emergency or urgency. In the hectic situation in the ER, differential diagnosis should be considered to avoid unnecessary and possible harmful treatment. Remember Hippocrates. Malignant hypertension is the first differential diagnosis. It's characterized by fibrinoid necrosis of small arteries. It's more progressive hypertensive retinopathy and more progressive renal failure with proteinuria and hematuria. And it is more permanent severe elevation of blood pressure, not acute, more chronic, permanent. Control of elevated blood pressure as inpatient is indicated in malignant hypertension. Possible therapy is oral ACE inhibitor, angiotensin receptor blocker. Sorry. Yeah. I am missing one slide. I don't know if it's here. But in conclusion, ladies and gentlemen, hypertensive emergencies and urgencies are clinical condition, clinical situation, clinical presentation associated with severe elevation of blood pressure, which need to be lowered rapidly, immediately, or gradually to prevent brain edema and increase in intracerebral pressure. But controlled. The aim systolic blood pressure should be 160, the aim diastolic blood pressure 110, to avoid sudden drop of blood pressure and reduction in cerebral perfusion. Differential diagnosis should be considered before starting possible harmful treatment. Medical treatment should be started according to the clinical presentation. Thank you for your attention.